Good evening, everybody. It's February 7th, and it's good to be with you on another virtual town hall, living with lupus and COVID-19 in our community. Um, my name is Sam Lim. I'm happy to be presenting to you today, and it's not like we don't have anything else going on. So for your football fans, we'll be sure to get through this. As always, I want to thank our co-sponsors, the Lupus Foundation of America, Georgia chapter, with Terry Iman, the Georgia Council for Lupus Education and Awareness, and the Emory University Division of Rheumatology with the Georgians Organized Against Lupus, or GOAL research cohort. As always, please be reminded that none of what I'm saying is to be taken as specific medical guidance for any individual, that you should always go to your healthcare professional to discuss any advice that pertains to you. So as we always do, we just start out with seeing how the numbers grow throughout the world. And you can see that there's over 105 million infections throughout the world, with over 2.2 million deaths. 27 of a million plus of those infections are from the US, with nearly 500,000 individuals in our country having passed away. Behind the US is India, Brazil, then Russia, and then UK. And then you can see that a lot of it, European countries continue to fill the rest of the list there. And as you can see, in terms of the hotspots, Europe continues to be quite active, especially some of the Western countries like Spain. But you have Sweden that continues to be very active, Eastern Europe, and then all of North America, especially the US and South America there. Very relatively little activity in Asia, apart from Russia. Now, this is all relative, of course. There's still activity going on throughout the world. And we're no exception here. This is what the US looked like a couple weeks ago when I was with you last. And this is what it looks like now. Still yellow and orange predominantly throughout the country, but relative to a couple weeks ago, much fewer in terms of the really dark red areas. If you do take a step back though and you look, there still continues to be a lot of activity in California and Arizona, but all throughout Texas, Oklahoma, Arkansas, and then especially South Carolina and North Carolina now, but not too far from us, and we're sort of in the middle here. But that all indicates a positive trend, and you can see that in terms of total number of cases in the US are starting to come down, the new cases, and the deaths always trail the new cases, and you're starting to see flattening, if not some beginning of some decreases there, and the hospitalizations are going down as well, which is good. And you can see all the numbers and the percentages here on the right. Another way to look at the US is just looking at the risk in terms of a dashboard, and this is COVID Act Now, just to, they put together different parameters, and I'll show you Georgia's COVID Act Now dashboard in a minute. But you can see that most of the country remains at relatively high risk, maybe not the most severe, but still very high. The areas that are relatively doing better are starting to show up in the northern plains, which was raging several months ago, as you might remember. And then going into Georgia, this is 2 weeks ago, and this is where we are recently, which is obviously much better. Still, again, pointing out to the fact that it remains quite active, but relatively better, which is a good sign. And that is being borne out in terms of the figures that we see in terms of new cases are going down a lot. And similar to the US, the deaths are starting to level out, and if not indicating some early decline. And what was quite scary, to be honest with you, just a few weeks ago in terms of overwhelming or the potential of overwhelming our hospitals, thankfully, it's starting to come down. And this has all been predictable, right? It's after the holidays, we were expecting about 2 to 4 weeks would be the peak. And things are starting to come down as a result of the time. Now, this is that COVID Act Now dashboard. On top is our last town hall. And you can see that in terms of overall markers, we continue to remain in the upper tier, active outbreaks, maybe not the highest, but the second highest, and that remains unchanged. But if you look at the individual parameters in terms of the daily new cases, they're going down, the infection rate is going down, the test positivity rate is going down. The ICU has remained stable, but that is starting to head down as well. You might remember in previous weeks, this COVID Act Now site had at the last parameter contact tracing, but that's basically thrown out the window because it's such a low percentage, and they decided to go with percent vaccinations, which is interesting and I think helpful in other ways too. And you can see the vaccine rate has slowly but surely going up. But there remains a lot of people who are unvaccinated. Obviously, there remains a lot of cases that are out there, and people are transmitting and people are getting infected. And so just as a reminder, here is an informal quiz for you. If, and this is hypothetical, I hope, if you are attending a Super Bowl party with 25 people and what is your risk of getting COVID infection? Assuming that nobody's vaccinated, you're partying indoors and you're eating and drinking. So just given the community level of COVID that's out there now, and you just say, heck with the masking, let's go and party indoors, and you have 25 people. What is your individual risk if you didn't have COVID, but not vaccinated, partying indoors? Well, it depends on the rate around you. And if you go to this Georgia Tech website, they use statistical modeling with real-time data to sort of, and you can kind of move the parameters in terms of the number of people. It's just an interesting mathematical site if you like those kind of things to visit and play around these theoretical scenarios. But if you were with 25 people and you were just randomly hanging out with them, partying indoors, in Fulton County, you have 30% chance of getting COVID. Nearly the same in DeKalb, higher in Cobb at 37%, and highest in Gwinnett, nearly half, 50-50 chance of getting COVID. So even though the rates are going down, it's just a reminder that there's a lot of risk out there that we all need to continue to be on guard. So what else is new since the last town hall? Well, just a reminder of what we've gone through, and thank goodness it's in the rearview mirror, but January was the deadliest month of the pandemic, averaging over 3,100 deaths a day, meaning 1 in 733 in the US had died from COVID-19 and 1 in 725 Georgians. There are new variants that we're hearing about, and we'll talk a little bit more about those in a minute. They continue to spread. They're probably mostly, well, not probably, they are definitely largely undetected because we don't have the system and we don't test the genomics of the different viruses throughout the US as much as other countries because of our poor public health system. The FDA plans to release draft guidance in the coming weeks with new standards for vaccine booster shots, tests, and treatment. So we'll have more in terms of general guidance there. The new CDC director, Dr. Walensky, said that vaccinating teachers should not be required to safely reopen schools. And as we talked about, the third surge is waning with daily cases down by 40%. And daily US hospitalization below 100,000 for the first time in over 2 months. We have a new federal mask mandate that's issued for forms of travel, planes, buses, public transportation, and while you're in any federal building. More than 119 million vaccine doses have been administered worldwide, with 37 million in the US. Big numbers, which is good, but still not nearly enough. Johnson & Johnson submitted an emergency use authorization application for its 1-dose vaccine on Thursday of this past week. And the advisory committee meets on February 26th. So assuming everything goes well, by the start of March, we should have another vaccine in our armamentarium. In the Biden administration plans, I'm sorry, I didn't include that, plans to ship vaccines directly to retail pharmacies. So if we have supply, and having another vaccine will certainly help that, but assuming we have supply, we'll be able to pipe that out to more and more locations. And it would be great to go to your local CVS or Walgreens or whatever, or Publix or Kroger to get your vaccine. Sorry about the busy figure here, but let me walk you through it. This is, time going left to right. And then going up and down is the percent of all deaths. And usually sort of the trend of deaths goes up and down over the year. That's the projected number of deaths usually. The threshold for that to be over and above what is normal is kind of this line, and you can see in this red line here is the number of deaths due to COVID, and you can see that it spiked up, and it's really sort of been along this epidemic line, and it's really gone. The rates have been crazy. Wait, I'm reading it wrong. No, sorry. The number of deaths in COVID really, because it wasn't around back in 2018, 2019, is in the blue over here. So you can see COVID really comes up and starts going high up and down. The thing that I wanted to point out here is this yellow stuff on the bottom here are the rates of deaths due to influenza. And the point I wanted to make out of this figure is that you see influenza deaths sort of peaking periodically, especially in the wintertime, as you can see, and we expect that every year. And it's been going up, and except this current season, and there has been basically no detectable pandemic issue with the influenza being a part of that. Basically, there has been no significant number of influenza deaths, which means that the number of infections of influenza has gone down a lot. And that makes sense given the fact that we're distanced, we're masking, and that's how influenza gets around. But it also underscores, again, the difference between influenza and COVID. I remember people in the early days of COVID said this is just basically another influenza that's going around. And in some sense, it's true, it's a respiratory virus. But if that were true, then the masking and the social distancing that we already have, that's dampened down, basically gotten rid of the spike in flu this season, would have had an effect on COVID, and obviously it certainly has not. You can see the dramatic impact on COVID there. There are interesting maps going out now, not only following COVID cases, but following vaccinations. And you can see that the areas of the world where vaccination is starting to ramp up. Now here, the US looks relatively good, but if you look at it, it's relatively few. We're talking about 6+ per 100 people, or 6% or so of the entire United States population is currently vaccinated. And we need to get to at least 70, 80% to have a significant effect in terms of a population like herd immunity, where we possibly might be able to move around freer with less risk of getting infected and perhaps have an impact on masking down the road. So hitting on a couple questions, is it safe for someone with lupus to take the vaccine? Has there been anyone that you're aware of that has had the vaccine? I believe we had similar, if not the same question last time, and we still don't know any specific information about the vaccine in lupus. It's probably going to come, but not for a while, at least a year, I would think. But there's theoretically not a big concern, but we don't know. And I think it really boils down to speaking with your healthcare professional. Although I think on paper, generally speaking, it should be acceptable. And yes, I do know several people with lupus that have qualified to get the vaccine as being part of the early risk groups of being over 65. And to my knowledge, everybody has done well. Again, small numbers, but I think it just supports the fact that most people will do well. Are the people giving out the vaccines asking if people have lupus and turning them away? No. The questions that are screened at the vaccine sites are really no different from what you would get when you would get any other vaccine like the flu shot. They ask if you have any known allergies to anything in the shot, if you've had a very severe reaction to any vaccine before, have you had any fevers recently, and so forth. They don't ask anything about whether you have lupus or not. So speaking further along the lines of vaccine, we have the two vaccines, the mRNA vaccines from Moderna and Pfizer that are currently approved for emergency use in the US. We're hearing a lot in the news about an AstraZeneca vaccine. I just mentioned about Johnson & Johnson that's applied for an emergency use authorization, and we should know within a few weeks, and it's a one-shot vaccine. There's a Novavax vaccine and a Sputnik, the Russian vaccine. And you might hear of these numbers. These are the more common ones that are being sort of bandied about. That's the efficacy of these vaccines. And when you hear the 90, 94%, 90%, and then Johnson & Johnson 72, and then you see all the other numbers here. On the surface, you might be tempted to say, well, I prefer the Pfizer or Moderna because it's mid-90s versus 72% of Johnson & Johnson. The reality is that you really should get if you're going to get it, you should get the vaccine that you can get the fastest. And for a while, it's going to be out of your control. Whatever your local area gets at the time that you qualify to get, there's probably going to be more demand than supply. So it's in your best interest to get what you get and get it quickly. But focusing on these numbers really misses the boat. You can look at all these other differences in terms of the clinical trials, how many people got it, what were the details, does it really apply to me? And not to say that that's not important, but when you look at the results of these studies, what's really important is, sure, I don't want to get anything related to COVID, but what I really don't want to get is severe disease, especially the ones that cause me to go to the hospital or pass away in an untimely fashion. And I think we would all agree on that. And if you look along those parameters, all of the vaccines are reporting very good numbers, and especially this protection from hospitalization and death. I don't think anything in life is 100% except for death and taxes. But for the time that they were getting data for these studies, they had achieved 100% in protection from hospitalization and deaths across all of the vaccines. So in the real world, it's not going to be 100%, but the fact that it performs so well in the studies is going to be very, very good. And it doesn't matter which vaccine it is. And even when you talk about severe disease that does not require hospitalization, they all perform very well. So we talked about the J&J, Johnson & Johnson COVID one-shot vaccine. It probably, if everything goes well, as people expect, that it should be approved and under the EUA and available probably sometime in early March. In terms of reviewing the clinical trial information, I do my best to stay on top of that. I am not an infectious disease expert. I try to relay information from what I hear at the times that I hear them and read myself. And so I'm assuming that I will look into the details of the Johnson & Johnson trial, and I will do my best to relay that to you. It is true that a majority of their patients did come from South America, including Brazil, and they may have had patients with lupus in it. No matter what study, though, it's not going to be a lot, and I think you can get some inkling if they do report the autoimmune subset. And whether they break that down into lupus, it's hard to say. I doubt it, but whatever we can glean from any information that may be informative to those who live with lupus, I will do my best. And if you hear of anything, please send it my way that we can teach each other. Now, when I talked about the performance of the vaccines, that's given the predominant type of COVID that it was designed against, and that is currently the predominant variant in the US. But as we're all hearing, things are changing. And as I've mentioned in the past, we totally expect the more times the virus transmits and replicates, that there's an increased chance of variants. So there's no question that we, in the scientific world anyway, had every expectation to have literally thousands and thousands of different variants around. And that is totally expected. And that happens with the flu, it happens with the cold. But one thing we do have to keep an eye out is how our current vaccines perform given these variants. And what just came out a few hours ago, hot off the presses, is that South Africa is not is looking at the data from the AstraZeneca vaccine, and they don't find it to be effective enough in even the mild or moderate cases based on what they've seen. Now, I haven't had too much time to look into this, and it just came out. From what I can tell, it looks like some early data. AstraZeneca has not been too forthcoming in terms of the detailed data, so there's a lot to be learned here. But this does remind us that as these variants come out, we need to know how they perform against the vaccines, and it's going to be a constant game of cat and mouse and adjusting and pivoting. So again, to be expected. But the good news is that the vast majority of the variants, including the South Africa virus, the current vaccines, Moderna and Pfizer, have some efficacy to it. Certainly there's less efficacy, but it's not as if it's a complete wash. So having the vaccine is going to be protective to a certain point. And there's a lot of questions down the road whether booster shots will help, and then of course new vaccines to adapt to the variants that are coming out will certainly be in play. So, but right now what we have is effective across the board, but to varying degrees. And we're tracking these things. And I showed you this map a couple of weeks ago. The CDC is showing states where they're seeing some of these variants coming about. The dark spots here in this map are what's commonly known as the UK variant, the B.1.1.7 lineage. By the way, I mean, this is an undercount. At any time we know of a case, clearly there's going to be some around in other states that just haven't been detected yet. So it's just a matter of time. And everybody is saying that, well, not everybody, but the CDC is predicting with high confidence that the UK variant will be the dominant variant in the US in a few weeks. So the CDC has changed that map that I just showed previously to this type of map, and it's starting to look at all different types of the significant variants that are known. And up top here is the UK variant, and the one in the middle is the South African variant, and the one at the bottom is commonly known as the Brazilian variant. But we're talking several hundred of the UK variant, which is going to be a huge undercount in the US, and this is across 33 states. So it's pretty clear that's going to continue with high speed and be spread pretty much throughout the US fairly soon. The UK and the South African variant here is the one that some people are more concerned about because the current vaccines have less efficacy against this one compared to the UK variant. We're still learning so much about them. There's still some debate as to whether any of these variants are more severe in terms of hospitalizations and deaths. We do know that especially the UK variant, which is what's driving it to be so spread throughout the world, but here in the US, is that it's so much more contagious than the previous or the current predominant variant of COVID. And so we're going to see more and more pop up, and we just need to kind of keep an eye on them and watch them, especially as to how the vaccines work. Is it true that a person can still get the virus after getting the vaccine? So let's kind of walk through this for a second. What does a vaccine do? So the vaccine allows your immune system to be trained and to have memory, which is important in terms of reaction to a future exposure to the virus. So if you get a vaccine to the flu shot, for the flu, for example, and that particular flu strain was to be exposed to you, then your immune system would be able to fight it much faster and more effectively, to the point, hopefully, that you don't get any symptoms. But if it's not a complete a response or a fast enough response, you may have some symptoms, but it's much better than if you were to not have been vaccinated. So same thing with the COVID vaccine. It doesn't prevent you from being exposed to COVID, right? So the vaccines don't create this invisible barrier around you. So if there is COVID around you, in the environment, in the air, and enough of it were in the air that you were to be exposed, and if you didn't have a mask or you weren't protected enough, that virus would get into your respiratory system. Hopefully, the vaccine would trigger enough immune response and memory so that that virus is not able to replicate very quickly and get a foothold and create symptoms, and that leads to poor outcomes. That maybe you might have a little sickness, or maybe you wouldn't feel anything at all because your immune response would be so good that it just squashes the virus at the point where it is trying to get a foothold and grow and have a home inside of your body. So the question now is, how effective are vaccines? We have a good idea from the study. The variants are coming. There's some effectiveness, but not completely. How much is enough to prevent people from going into the hospital or dying more than they should? And also, when you have the COVID in your lungs, if it's not a full immune reaction and that COVID virus is replicating maybe not fully invading your body yet, but replicating enough that there's a decent amount in your lungs where it gives you some symptoms and you're coughing, maybe a little bit, not too much, but enough that those viruses, they want you to cough out, they want to grow, and they want to you to cough it out so that you can infect other people. We don't know if these vaccines have that effect yet, or how much of it. There seems to be early data that there is reduction in transmission, that if you were a vaccinated person with a good immune response, the chance of you transmitting that virus for that temporary time that you are exposed to it and you have some of it in your body, that it is lowered. And that makes sense. But how much is it enough to get people around you just not worry about you at all? So we don't know this. And that's why, in part, the instructions even after getting a vaccine is to mask, is so that you not only that you protect yourself, because the vaccines are not 100% foolproof, but also in the situation where you were to be colonized by the virus, maybe not symptomatic because you're having a good response, but perhaps you're still infectious to others, you're able to, even just in speaking or singing or laughing around somebody, that you're able to spray enough of that virus in the air so that it infects somebody who does not have enough immunization or is of high risk. So there's so many questions. Again, we're working very hard to get it. There are a lot of smart people around. I know answers aren't coming fast enough, but that's why we still need to be on our game and continue to do what we're doing, well past the point of the vaccines rolling out. Speaking about all the other things that we need to continue to do, given the Super Bowl is going on right now, I wanted to bring this up. Here's the last quiz of the day or the evening about how many COVID-19 PCR tests were conducted through the NFL monitoring period between August and through November. They did over 623,000 COVID PCR tests just within the NFL. And not that they haven't had any infections or outbreaks, but they were able to have pretty much essential full season into the Super Bowl because of not the vaccine, but because of having tight measures that we know work even without the vaccine. So beginning in July, they had mandatory masking, they had physical distancing, frequent hand washing, disinfection, restricted access to the facilities. And they had regular frequent testing of players and staff by PCR, which is really the gold standard for testing, initially 6 days a week. And they had contact tracing that, if you had to diagram it ideally, this is how they did it. I mean, they had true contact tracing. They had wearable devices that were worn and mandated to be worn in practice, so that if anybody were to test positive, they can go to that device and it records consecutive and cumulative minutes of interactions with others that were within 6 feet of you. And so they can then trace the people that cross a certain threshold within a certain period of time, within a certain distance of that infected individual, and then isolate them. So they were really on top of things. And obviously, it's not something you can do very easily across a country, but it does remind you that all this stuff works outside of the vaccine. And if you put everything together, that's a powerful tool. So we need to continue to do that. We had a comment, which I think is a question. Someone wanted to know about the effect of steroids on the immune system in the context of COVID. And I'll start by kind of talking generally that there's a recent study that came out that kind of underscored a previous study, in that autoimmune patients really didn't face a higher risk of death, even being on immunosuppressive medications, which is good and reassuring. Again, it's not lupus specific, but there were lupus patients within the groups that were being studied. So this particular study is very similar, and it supports the previous findings in that those with underlying autoimmune and chronic inflammatory conditions, there was reassuring information that there was not an increased number of deaths. But they did find that the potential use of prednisone or corticosteroids was associated with increased death. And let me kind of talk about that. This was a multi-center study, and they were looking at the risk of people going into ICUs and being in a ventilator or dying associated with COVID-19. And they were following people with autoimmune or chronic inflammatory conditions. And there was a whole host of things like inflammatory bowel disease, psoriatic arthritis, rheumatoid arthritis, but there were a decent number of people with lupus in there. And they looked at electronic health record data from 5 hospitals within the Mount Sinai hospital system in New York. And they followed people who were tested positive for COVID-19 earlier this year. And they found, a lot of people who had COVID-19, and about 2.3% of these people had an underlying autoimmune disease, RA, lupus, inflammatory bowel disease, and many others. And they did not see a difference between the autoimmune disease group and the general population that had COVID in terms of the risk of being on mechanical ventilation or dying, which is good. Now, they did pick up on some things, though, that were risk factors outside of having autoimmune disease. So just because autoimmune disease in general doesn't seem to have a signal with higher risk of poor outcomes, it still doesn't mean that you don't have other risk factors. And I'll come back to the steroids in a second, but they did find that people who were female, obese, history of asthma, and especially those with a history of cancer were definitely more likely admitted into the hospital, and they had higher rates of being ventilated or dying. They did find also that in terms of one medication, all the medications that suppress the immune system, including the many ones that people with lupus take, were not associated with poor outcomes, but the exception were steroids. So there's something about prednisone and corticosteroids that when given more long-term, and that's how it's used in these conditions generally, right? You may get a burst of steroids here and there with lupus, but most people, when they are on steroids, it's for a longer period of time, that is an increased risk of poor outcomes. We do use steroids in COVID when people are really, really sick in the ICU, and that has saved lives, and that's been helpful. So steroids it's a double-edged sword for everything. When used very short-term in COVID, in certain very sick people, it is helpful. But when you're on it for a while, having had lupus, that is going to be one of the risk factors, it appears, to poor outcome. Now, the take-home message here is not to stop your steroids, because the last thing you want to do is have worsening lupus in the setting of what's going on. And that's going to have its issues too. But it does underscore a concept that should have been around even before COVID, that we already know that prednisone and steroids are associated with a lot of things that we don't like when they're used for a long time at higher doses. So you should constantly try to get on as low a dose as possible to have the maximum benefit. But if you're not completely off of it, it's not something that you need to be terribly anxious about, but work with your healthcare team with this information and make a plan over the coming months to do the best that you can and to get as low as you can. And once you get to that point, if it's not zero, then just be happy that you've tried your best. And there are many other issues to deal with, but certainly the last thing we want is your lupus to flare. And this data kind of supports that. What we're seeing in the emergency rooms, including Grady and Emory, is that once the pandemic started, the emergency room visits dropped. I mean, they've come back up to a little bit, but they're not back at the levels where they were before the pandemic. And you can imagine all the reasons why, including people are not going to go to the ER unless it's really obvious or very severe. But unfortunately, what that's turned into is that the percentage of people in the ER that get admitted into the hospital because they are really, really sick has gone up. So even though the volume of people in the ER has gone down, those that are going to the ER are much sicker. And this is for everybody in general, but I've seen this anecdotally in people with lupus in the hospitals where I'm seeing patients, that people are coming in much sicker. And it has a lot to do with delay in care and not being able to control the lupus itself as well, because of some of the limitations that COVID has given us. So all that is to kind of offset what I just told you. The big picture is reassuring that having lupus, being on a variety of the medications, whether it be azathioprine, mycophenolate, rituximab, it doesn't seem like these medications are at high risk for poor outcomes. Yes, there is a signal with prednisone, and we do need to be on as low of it as possible, but prednisone does help manage symptoms very well in some people. And the last thing you want to do is come off of that too quickly so that your lupus gets really bad and you get hospitalized for that. Some other questions here: are antiviral medications useful in lupus type conditions? There are no, if you're talking about COVID in particular, there are no medicines that are antiviral for COVID yet. We have for flu some medications where if you take it early on in the infection of the flu, it slows the reproduction of the flu virus, and so your sickness isn't as bad. I'm very optimistic, actually, that we'll have medications like that down the road. We haven't heard of any of that in the news lately, but there's a ton of research being done in it and some promising ways to do that. But there are no antiviral medications for COVID. But if you're talking about antiviral medications in general, there's no theoretical reason why someone with lupus could not take that. Are blood transfusions beneficial to support lupus conditions during this epidemic? I mean, if you're anemic, unless it's severe anemia, which would have been treated without the COVID anyway, there's no benefit to having a transfusion with respect to protecting yourself or sort of minimizing the severity of COVID if you were to get it. Nor am I aware of any information along those lines as it relates to people with lupus. So I don't know of any link there with blood transfusions during this time, especially with COVID. So there's no specific guidance there. Last questions, and these are the ones that I can't answer. I'm sorry. So the anti-inflammatory drugs best for use for lupus pain and inflammation. These town halls, I'm focusing on COVID-specific questions, which is the point of the COVID-19 town halls. We may eventually down the road have a time for general questions for lupus, but I just wanted to be very focused in terms of the topic and keep this COVID specific. Otherwise, we're going to have every question about anything in lupus, and I would love to be able to spend time to talk about that with you all as a general education. And we could and we should do that periodically, but it's not something I can commit to, in this venue every other week, especially in the context of the short time that we have to focus on COVID. And then the question or the point in the bottom here is just a very specific question for some individual. It's not very general in terms of education, nor is it related to COVID. So I'm not able to answer that. I'm sorry. So that's it. I think we're still in the third quarter of the game, for those of you still interested. But I appreciate your time, and I love being able to spend this time with you. I hope you continue to find it useful. And it's certainly not the end all. There's a lot of great information out there. And if you want to go to a trusted site, please go to the lupusga.org website, where Terry continues to assemble up-to-date news and resources for those with lupus and COVID. The national website continues to have information that's linked as well through the Georgia site. And please continue to keep sending your questions to us every week. And again, let me see here. I don't know what the base URL. I'm just looking at the chat box here. Okay, so I see Terry, you responded to Corliss. Great. Thank you all. Have a great week and stay safe. And I hope to see you again in a couple of weeks.